All right, so now that you guys are eating, you can. Fortunately, I don't have a full lecture because otherwise that sugar or the insulin crash afterwards, you guys would all be asleep. So, thank goodness it's only a review. So I'll start off. Any questions I can answer for you guys? Everyone watch the endocrine video? No. How will you know if you have questions if you don't watch it beforehand? Yes.
So, in terms of like insulin injections, so in terms of compliance with medication, you said fewer injections are best.
Fewer injections are better.
Fewer injections, you said, could also lead to or have a higher risk for hyperglycemia.
Yes.
How do you balance that?
How do you balance? That's a great question. So most patients get started on a very similar regimen. I don't see a ton of things like NPH being used super frequently anymore, but before like things like your Lantus and your Dedamirs and things like that came out, like you saw a lot more NPHs and more intermediate to long-acting agents being used. But nowadays it's usually one of the, like, Levemir, Lantus, or that new one that Insulin Degludec is the generic name, but anyway, that's the newer one that has like the longest duration of action. So most patients usually end up getting put on usually kind of like a 4 injection type of schedule where they have like mealtime injections, and they'll have like their long acting usually in the morning time. The more injections that you can have, the tighter control you can get on the actual glucose, right? But then the more insulin you're giving, the more likely you are to have hypoglycemia. So ideally what you'd have is like, kind of like a continuous insulin drip. Like we do that for a lot of ICU patients in order to help maintain their glucose, because we found that if you let their glucose ride too high, you can end up seeing increases in mortality and things like that. So some of them end up getting put on insulin drips to help manage that. And that's something where you can like do your AccuChecks and you can titrate the drip exactly to maintain, consistent blood sugar, right? So that's like the ideal, which is what your pancreas is doing anyway, but we can't obviously achieve that with sub-Q injections typically. So fewer injections, better for compliance, but you're going to have way bigger spikes in your blood sugar than you would otherwise. So usually around 4 injections or so is kind of that sweet spot. Some people may need more, some people will maybe get away with less, but that's typical. What other questions do you have? You're experts on all subjects now? Yes. My job here is done.
Can you refresh us on the collateral alcohol, what did you call it, disulfiram reaction?
Yeah, the disulfiram reaction. You guys, anyone explain that?
Like, is that when they like start vomiting profusely?
They will potentially start vomiting. So alcohol usually gets metabolized by 2 main enzymes. There's an alcohol dehydrogenase, and then there's an acetaldehyde dehydrogenase, right? So an alcohol, ethanol, gets broken down into acetaldehyde. If that builds up, that ends up causing a lot of flushing, a lot of vasodilation, makes you feel very nauseous, makes you throw up. So if you had something that were to inhibit acetaldehyde dehydrogenase, that would also lead to buildup of those levels as well. So there's a drug called disulfiram, which is called antabuse. It was originally used for alcohol addicted patients to hopefully prevent them from making it so intolerable when they drank that they didn't want to drink anymore. Metronidazole reportedly does the same thing. So it inhibits acetaldehyde dehydrogenase. You build up levels of that when you drink, and then you feel really crummy. You don't want to drink anymore. Sure.
Can you explain how with higher insulin levels you get weight gain?
Yeah, so anytime you have increased insulin levels, whether it be from exogenous injections of insulin or from drugs that increase insulin levels, so say for instance like your sulfonylureas are probably the biggest offenders of this, you end up getting weight gain, right? And if you think about insulin being an anabolic steroid, it makes a lot more sense, right? So there are like bodybuilders who will use insulin after workouts when they're consuming a lot of calories and things like that in order to help achieve muscle growth and things like that. Essentially, when you have activation of insulin receptors on those, skeletal muscle tissues and things like that, that's kind of stimulating increased influx of glucose into those tissues, right? Because you're kind of sensing, okay, you need to build up glycogen stores, we need to, need energy. You're not just taking in carbohydrates, but you're also taking in amino acids, you're taking in other nutrients, electrolytes, things like that. And so all of those things lead to, tissue generation and growth. If you have excess glycogen being stored up or excess carbohydrates, that all gets turned into adipose tissue, right? So that's where you get the weight gain from eventually. So that's why you see things that sensitize the body to insulin to make the insulin work better actually cause weight loss in general. So things like metformin typically is a little bit more favorable to weight, but certainly like your GLP-1 agonists, we saw those cause pretty significant weight loss as well, because just they're sensitizing the body to insulin helps it to work better. Does that make sense? So all these patients, you know, they're not bodybuilders, they're not working out very much, so all that extra carbohydrates and stuff like that, it just gets turned into adipose tissue rather than being turned into like muscle.
So if you're like diabetic being managed on metformin, at what point would you start managing them with insulin therapy on top of that?
So depends on the type of patient. Usually you try to manage them with kind of multiple oral meds before switching over to insulin. Usually it's one of those things where like once you start them on insulin, like they're usually stuck on that, you know, because a lot of times like they've failed lifestyle modifications or they're not really making the changes they need to do to be successful without insulin. So that's usually one of those things like kind of once you put them on it, they're probably going to be on it for foreseeable future, right? Until they decide they don't want to do it anymore. So usually you use kind of multiple meds, which is why or multiple oral meds, which is why you see metformin being in combination with so many other types of medications. So you see metformin mixed in with some of the thiazolidinediones, those TZDs. You'll see it mixed with a lot of the sulfonylureas, right? So you see like Metaglip or something like that will have metformin plus glipizide put together. So lots of combination products to make your compliance a little bit better for those patients, right? So normally once you try kind of multiple medications, you're trying usually insulin sensitizers plus, you know, sulfonylurea, which is also making more insulin. If none of those agents are really working, and now that we have like the GLP-1 agonists, like your exenatides and things like that, you have the SLGT2 transporter blockers, like, you know, we have more options to try. Once they've kind of failed multiple therapies, then you kind of say, okay, let's try insulin. Because insulin's going to work, you know, it's just a matter of like how big of a dose do you need to really overcome that insulin sensitivity. So I have patients I've seen who are like in the ICU, they are, you know, 500 plus pounds and they require just massive doses of insulin because they're so resistant to it. Their pancreas really isn't sending out much anymore, but to overcome that resistance, you have to give just huge doses. That's where you get like the U500s and the more concentrated insulins, where you can really get into trouble if you kind of goof up the dosing on that.
Why would you choose a sulfonylurea over like an SGLT2 or a GLP that'll help you lose weight on top of?
That's a good question. So if you talk to someone who probably deals with these patients a little more frequently, they might have a better answer for you. For a while, the sulfonylureas were just the most. So if you were looking at like kind of like before like the GLP-1 agonists came out, before you had like back in the time when like the thiazolidinediones and the TZDs, like those were like kind of the newest agents, we didn't have a ton of options, and so like insulin sensitivity, like insulin sensitizers only got you so far, so you needed something like a sulfonylurea to help increase insulin production or increase insulin release, right? So that was really one of the most effective drugs in order to get your blood sugars down and get your A1C under control. But now that we have these newer agents, a lot of people are trying to use those instead. But if you consider that a lot of those are brand name products, a lot of those are injectable products, those tend to be more expensive. So you may see like, well, sulfonylurea is, you know, covered by their insurance or it's cheap enough where they can afford it, right? So that might be a reason why you go with that versus some of the newer ones. And then also consider things like, you know, the side effect profile. You know, if I have a patient who's got, you know, recurrent UTIs, I don't want to give them, you know, canagliflozin because it can cause a fungal UTI. Like that would be not a great thing to do, right? So you have to take a lot of those kind of considerations into account.
Okay, so I was really confused about the alpha
Glucosidase. Mm-hmm.
It's not absorbing the glucose into the GI tract,
Mm-hmm.
right? So where is it? Is it just then like glucose just being excreted through the kidneys?
No, it doesn't actually get into the systemic circulation at all. So instead, like you know, again, you take the alpha glucosidase inhibitors with food, right? And so instead of it getting absorbed through the GI tract and then getting into the bloodstream, it just stays there in the GI tract, right? And then your colonic bacteria can start to metabolize it, and it turns it into lots of methane, and then that's why you get the flatulence, the abdominal cramps, and things like that. So that's really how those drugs are working. All the excess, you know, basically, you know, whatever blood glucose you have in your system is basically just what's there. You're just preventing new glucose from getting in.
So it's basically working on the metabolism of the carbohydrate as opposed to insulin or glucose transport?
Yeah, it's basically just blocking that transport from the GI tract into the systemic circulation. Mm-hmm. So it's basically all of it is being kept in the GI tract, which is why you see, that might be preferable, like in some pregnant patients if they couldn't tolerate insulin for whatever reason, but also why you see a lot of the GI side effects with it. Those drugs we almost never use. At least I've never seen them being used. The TZDs I see used with some frequency. Sulfonylurea certainly. Metformin, like almost everyone should be on metformin if you're type 2 diabetic. Probably even some type 1 diabetics could even benefit from it, especially if they've been on really high insulin doses or things like that, like because again it's just making insulin work better in the peripheral tissues and in the liver, right? So that might be a rare occurrence, you might see that. And then the newer agents, obviously, like the GLP-1 agonists are certainly getting a lot of use just due to their weight loss properties. Like I mentioned, my uncle got put on that when he lost a ton of weight on that stuff. It's basically just a shadow of his former self. But again, it's like all that satiety, all the kind of central effects was making him just not hungry, so he just stopped eating, right? Which can also have kind of deleterious effects that goes too far in the other direction.
Can you explain again why nucleotides are taken before meals? Is that to compensate for glucose consuming, or is that a different mechanism?
No, it's due to the mechanism, right? So think of like the sulfonylureas and the meglitinides kind of working through the same process, right? So they're still working on the beta cells to increase insulin release. It's just sulfonylureas work no matter what. They'll always work to increase insulin release. The meglitinides only really work if you have glucose absorption happening, usually from food, right? That's the only time they're really going to help stimulate insulin release. So if I gave it like during a fasting period where they weren't eating, you really wouldn't see a lot of insulin extra insulin being released, right? But if I take it with food, then that's where you see it to work more similarly to the sulfonylureas, which is probably why they don't get used very frequently. It's really, the sulfonylureas get more use.
Okay, so with when you're type 2 diabetic, and eventually I was reading that after a while you're gonna becoming unable to be able to release insulin versus becoming resistant after a while. Is that true?
Yeah, they wear out the pancreas after a while.
And
Yeah.
then, so is that the time when you start to that you're able to give a type 2 diabetic insulin?
That is a good time. Yeah, so if you get to a point where like things like sulfonylureas are not really working anymore, or you start to see like even though they're on the same medications that they've been well controlled on for a long time, and now they're starting to become less and less effective, that could be a sign of diminishing beta cell function, right? Because remember that one slide, like they usually don't get diagnosed till they've almost had like 50% reduction in their beta cell capacity, right? So you've lost a lot of function by the time you get to a point where you're actually being diagnosed with type 2 diabetes for the most part, right? So by the time that gets even further along, if things like sulfonylureas aren't really working, that's when you consider adding on like insulin. That's a good place to consider adding on insulin, right? Go ahead.
When we were talking about our incretins and helping regulate gastric emptying, does that have anything to do with gastroparesis?
It will. I've not seen where it worsens gastroparesis. Do you guys know what that is? What is that?
The nerves.
Yeah, so like the stomach's basically not really, gastric emptying time is slowed to a point now where like a lot of food's not really passing through the stomach as it should, and so that's when they throw up and it looks like it's kind of undigested food. So that's usually related to like kind of neuropathies that are happening kind of chronically for some of these diabetics. So I've not seen where that worsens gastroparesis necessarily, but certainly by decreasing that gastric emptying or slowing down the gastric emptying time, like food sticks around for longer, you feel fuller, and so that probably helps with the satiety feelings as well, right? So kind of having those stretch receptors being activated for longer makes you feel like you just had a big meal and you don't want to eat anymore. But that could be a possibility if there had some nausea, vomiting associated with that. You could maybe have a worsening gastroparesis. I just haven't heard of it.
So it's not the equivalent of.
Yeah, it's not like you're inducing gastroparesis.
Right.
Yeah. But it would be almost like to a lesser degree. So it's like gastroparesis is like you're just really not moving anything, and that's when you're throwing up all that the food that's not really even been digested just because it's just sitting there. This just kind of slows it down to a mild degree. Right, because it's also working centrally, and increasing the satiety feeling. Yeah. Any other questions? Okay, so I just have a couple. Oh, go ahead.
Well, so if we were to have a question like, what's the go-to medication for newly diagnosed type 2 diabetic? It would be like metformin, and then.
Well, who wouldn't use metformin in? Most type 1 diabetics. Okay, who else? Yeah, kid. Yeah, so remember, like if they have if a poor GFR, right? Because before it used to do it based on serum creatinine levels. It used to say, if it was like 1.4 for females, 1.5 for guys. Why do you think the serum creatinine level is different from guys to females?
They have more muscles.
Yeah, guys typically have more muscle mass for their body weight, and so that's why they have a little bit higher creatinine. So that's why that difference was there. But nowadays they're just saying, okay, if it's if you have GFR below 30 or whatever it happens to be, whatever's on my slide. I'm having to learn new stuff along with you guys sometimes. Basically, don't do it because you end up having build up the metformin, and then what can you have happen?
Toxicity.
What type of toxicity? No. Lactic acidosis, yeah. So you can have, so that's especially the issue you run into. So if you get contrast, like if you get IV contrast, that you need to go for like a CT or something. It's not a drug you should always screen on their medication list is metformin, right? Because you really don't want to cause a contrast-induced nephropathy. You guys remember that when we talked about it in the renal stuff, right, last semester? You guys probably repress those memories, but if you can go back and look at your slides, I guarantee it was on there. But yeah, you're screening for metformin use because if you cause a contrast-induced nephropathy in that acute kidney injury, you have build up of metformin, then you can have that lactic acidosis occur. All right, so that's really the big thing you want to watch out for, and it's it's led to deaths in some cases, especially your older, kind of more frail patients. It's been very, very problematic. So oftentimes we'll make sure that you've been off your metformin for at least 2 days, or using more kind of low osmolar contrast agents have kind of helped a lot with that, but it's still a risk.
So if you are taking someone off of metformin for like a surgery, are you going to give them like add on a sulfonylurea so that the insulin that they are producing is being?
No, I'd probably more often see them being put on a sliding scale insulin regimen. Probably most likely. So like they had to come off of all their, usually it's just a few days, like a few days of hyperglycemia probably isn't going to have any long-lasting effects on your patient, but say they get like really bad stress-induced hyperglycemia, related to the surgery and things, like it's easier just to put them on a sliding scale insulin regimen while they're in-house because, one, they've kind of forced compliance, you're checking IQ checks pretty frequently, so you can get basically just, adjust their insulin as needed and then put them back on their oral meds when they leave. Yeah, so a lot of patients, especially ICU patients, get, like I mentioned with that hyperglycemia, you worry about that causing increased risk for infection and death and things like that. So really, glucose control is important for those type patients as well.
So when you put patients on metformin, if they're also working on lifestyle modifications, do you advise against heavy exercise? Like to what extent is lactic acid?
No, so you're right. So when you start exercising, right, you get sore muscles. That's from lactic acid, right? Because your muscles are going into more anaerobic states, so they can't utilize glucose and oxygen appropriately, so they end up making lactic acid. So that's why they get sore. That's a very good question. Like, should you really worry about that? Perhaps if they have poor kidney function beforehand, that might be problematic. But usually you have more issues of really not so much, because again, these are patients who obviously you want to tell them like kind of ease into exercise. Like you don't want them to go like trying to do 300-pound squats the first day, because otherwise the rhabdo is probably going to get them before the lactic acidosis does, right? That's usually the problem you run into, is like someone tries like way too hard to get into a new regimen, and they either harm themselves either due to just accidents, or they get like rhabdo, secondary not being well hydrated, things like that. I would certainly make sure they stay well hydrated, because that can also help to dilute out lactic acid as well. Usually you just give them like take a walk every single day. Like that's usually a good start for a lot of these type of patients, right? Like skip the big gulp, no Mountain Dew for you, maybe diet, but take a walk around the park. Like that's usually a good start for a lot of these type patients, right? And also consider like these older patients who are overweight, they have osteoarthritis issues, so like that can also be impacting things like kidney function. If I had to put you on an NSAID to help with their osteoarthritis and just lots of other issues that factor into it. So these are oftentimes patients with lots of comorbidities. You have to kind of weigh, when you add on a new medication, how's this going to affect everything else really, and lifestyle modifications as well. Anything else?
So would you ask it like, if someone was just diagnosed with diabetes, would you be like, what's the best go-to treatment? Encourage lifestyle modifications, diet, and exercise? Or would you be like, take metformin?
So that depends on the patient. Like you have to have a good conversation. So I know see what you're getting at. You want to know for test question purposes,
No, I'm saying it
right?
in real
Yeah, when
saying, you know what, I have my patient.
right, so sometimes, like, talking to your patients, you have to figure out kind of what their values are, what their priorities are. For a lot of them, they're like, yeah, I'm not going to do any of that stuff. Just give me the pill, right? You'll have some patients like that. You'll have some who are who will tell you that they're really motivated and probably not follow through with a lot of the stuff. So they might still benefit from medications. There is a slim subset who are like, you know what, this is a wake up call. I'm gonna go and get on a diet. I'm gonna start exercising regularly, and they're gonna come back, lost 30 pounds, and their sugars are gonna be totally in control, right? That's awesome if that works. That's not going to be the majority of patients, probably. Maybe my cynicism is getting the better of me, but probably not going to happen. So a lot of them are going to benefit from having insulin sensitizers anyway, though, right? Because remember, these are patients who have had chronic oversecretion of insulin to help manage all this hyperglycemia that they've been kind of subjecting themselves to. So having them at Metformin on board is only going to help them help the insulin they have work even better, right? So it's probably not a bad idea to start them on it anyway, right? Less drugs is usually better, but in this case, these patients could really, potentially benefit from it. For a test question purposes, I might, say like, okay, you have a new diagnosis patient. So say, for instance, I had like, a new patient came in, new diagnosis, type 1 diabetic. Which of these medications would be best to start on them, right? And so you'd have to key out, okay, well, it's a type 1 diabetic, so, metformin is probably not going to be super useful for them. Sulfonylurea is definitely not going to work for them. Insulin's probably the best option, right? Or if I had, say, a pregnant patient who had gestational diabetes, what's going to be the best option for them? Insulin's the best option for them, right? Because again, insulin is a natural product, so your body makes it all the time. It's not going to be teratogenic, right? So for gestational diabetes, that's oftentimes what we recommend if they are not able to control it just with diet alone. If I said, you had a patient with type 2 diabetes, had poor kidney function, their GFR is only 15, what might be a better option for them? Not metformin. So you'd have to key on that sort of thing, right? So look for contraindications, look for drug interactions that may pop up, different things like that. I won't try to trick you and just be like, oh, lifestyle modifications is the right answer there. Like, usually it'll be like, you have 4 drug choices and you pick whichever one's best.
And then for exogenous insulin, if you have a type 1 diabetic, you would go with like a mainstay, like long acting insulin. And then for meals, you do the fast.
Yeah, so we used to do this a lot in the outpatient pharmacy at Nemours. So we get a lot of those new diagnosis diabetics that are either being discharged from the inpatient side or they were coming from the endocrinologist clinic. And so they would have a very typical regimen of meds that they were put on all at one time. So you come in with like 9 or 10 scripts for different things, right? So a lot of it was supplies, so you have to give scripts for the glucose meter, for the glucose test, or the strips, the actual lancets, the syringes they're going to use, the needles are going to have, so it's already like 5 scripts you got right there, right? And then also the medication. So oftentimes they get given a as needed glucagon kit. Usually I see that. They will be given a fast-acting insulin, usually like either Humalog or Novolog is probably the most common ones I see being used, and then usually a long-acting. So they'll usually get like Lantus, so many units in the morning, with their short-acting ones, at mealtime, basically used as directed, and they've got already instructions for, their carb corrections or whatever happens to be. Or their sliding scale, whatever has to be put on. I see a lot of the pediatric endocrinologists using carb counting nowadays. Like they'll end up finding what their kind of their I'm trying to think of the word, like their calibration for it. So basically, like how much 1 unit of insulin will correct for this many number of carbs, this many grams. And so once they get that number kind of figured out for your patients, and that's going to be a lot more kind of streamlined for them. So they know that, okay, I'm ingesting this many carbohydrates, I need to inject this many units of insulin to account for that. So that's probably most common, is what I see.
Also, in your lecture, you talked about sliding scale versus carb counting. I think you used the pizza example too. Is that typically where, like, the difference between the two? Am I confused?
Yep. So, so as I mentioned, like the carb counting is a little bit more proactive. So you're saying like, okay, I'm going to ingest this many carbohydrates, I'm going to use this many units of insulin, versus the sliding scale is more doing like a preprandial glucose check. You're already saying like, oh, I'm already this high, this is how many units I need to take to account for that, right? So it's a little bit more kind of a reactive means of doing it. So nowadays what I see them is using more the carb counting to be a little bit more proactive about that sort of thing.
Does it depend on patient? 'Cause in the hospital, it was both.
Mm-hmm.
I don't know if it was nurse preference or.
Not usually nurse preference. If it was, usually you would have, I'm trying to think, different ways they would do it. It depends. So one, it might be on practitioner based, right? So what the kind of they've been doing, like, you know, older school guys might do more sliding scales. Some of the newer guys just coming out of residency or fellowship might be doing more of the carb counting. So that may be practitioner dependent. Some of it may have been what the patient was on prior to coming into the hospital, right? A lot of times if we are doing sliding scale insulin regimens for patients who are in the house, you know, we took them off their oral meds and we were putting them on that. Usually it'll be a sliding scale that we'll put them on. They're not going to necessarily have carb counting because we don't really know what their insulin sensitivity factor is, right, for that sort of thing. So for those type patients, sliding scale makes more sense.
So kind of piggybacking off Christine's
wow, there's not even that many of you guys.
So you actually, so you can mix a fast acting with a basal insulin?
Yeah, you should. Yeah.
Oh, okay, because I remember reading from another slide that you absolutely don't, you know, do it. So
when you're in the syringe, right?
So, just that.
Yeah, so there's some stuff with syringe mixing. So back in the day when MPHs used to be used more frequently, those came in a cloudy mixture.
Right.
And so in order to reduce the number of injections, you'd have to give people who mix their short acting with their longer acting agents, or especially for like the morning time insulin dose, like, you know, before breakfast. And so you know, so you always do your clear before you're cloudy because you don't want to mix the long acting, because basically you're drawing them out of the same vials. You didn't want to inject your long acting form into the short acting one, because if you got those mixed up and then you were injecting some of the long acting stuff around mealtime, then you might get hypoglycemic from that. So it was one of those things where they'd be able to mix them, but they had to be educated on how to do that appropriately. Nowadays, you never want to use the usually the long acting ones are coming in their own pens, you know, so there really wouldn't be a chance to do this anyway. Have you seen those pens before? Basically, you dial in the dose that you're going to administer. There's like a little pen needle that you'll screw onto it, and then they just press a button, basically, right? Some of those can be problematic, especially if patients have poor eyesight, because you already mentioned diabetics can have vision disturbances, you know, after a while. So that can actually be tough for them to actually measure out how much you're going to give. But yeah, so everyone for the most part will be on multiple types. Sometimes you'll see type 2 diabetics maybe just being put on a long acting. They may not actually be put on just mealtime insulins, but you may see that occasionally. But like a type 1 diabetic is at least on 2 different types of insulin.
But if you have a pump, it's usually just infused in a fast acting throughout 24
Yep.
hours.
Yeah, because then at that point you can more easily titrate a short-acting insulin than you can a long-acting one, right? Because once I give that long-acting insulin, like it's there, it's lasting for 24 hours at least. The short-acting insulin, though, it's a lot more titratable. Good questions. Good stuff. And I'm not even like that well versed in diabetes. I don't even deal with it all the time, but it's a very interesting subject. So if you guys get like, you know, it's a lot of good educators out there. So if you can't, like on rotations, like go just bend their ear for a while, and you know, like I'm not even getting into all the nutrition stuff that goes into it. Like I'm just talking about the meds, you know. So lots and lots of stuff to learn on diabetes. Thank you. I appreciate that. That's the highest praise I can receive. Yeah.
I would trust you with my health.
I would not, but that's okay. Okay. I just need like an epileptic patient to be like, you did a pretty good job on that. But yes. All right. Anyway, okay. Okay. Yeah, and so it's nice because like those kids, like they have we have nutritionists all around on them, at least on the inpatient side. You know, great educators and stuff, and you know, so it's especially when you get them early and get them young, they're like sponges, so they can take in all this information, assimilate it, and be really empowered to kind of manage their own disease state. Which a lot of cases you can't really do that, but for diabetes it's kind of one of those special circumstances where you know, educating is oftentimes the most important thing you can do for those patients. Okay. Any other questions? That's all I hand up.
Can you cover the calculation, like for the type 1 diabetes insulin dose with the bolus and basal? basal?
Yes, I will not make you calculate that on the exam. I was more doing that for illustrative purposes.
Because I don't know, like, how you get the 20%, the 15, or 15.
Yep.
But I know it's like 22 times, you know.
Yeah, so say for instance you were starting out a patient, so let's say we have, and again this is like kind of pretty rudimentary, there's probably a lot more kind of sophisticated methods that like endocrinologists would use to figure out their actual regimens, but for the most part, you know, if you had to do it today, start someone out on an insulin regimen, say you had a type 1 diabetic, let's say we're going to do like a half unit per kilo per day. Right, so let's just use that as our kind of round number. So we'll use that many. That's how we determine how many units we're going to give a day of insulin, and then 50% of that should be your long acting. 50% of it should be your short acting. Okay, so that means that 50% of that dose, whatever it happens to be, so you know, it ends up being like 0.25 units per kilo in this circumstance, would be like Lantus, or it would be the Levemir, right? Those are like 2 long actings. So they would basically inject that in the morning. That would be 50% of their insulin done for the day. Okay, that's acting all throughout the day to get their basal insulin supply. For the mealtime insulin, usually because, you know, with breakfast you're usually maybe ingesting a few more carbs there. They usually try to shunt a few more of the percentage points towards breakfast. So that's why you get 20% of the rest of the insulin dose with short acting for breakfast, and then 15 and 15. So if you add those up, it's 50%. So basically you're just kind of dividing up how the rest of the insulin gets broken up throughout the day.
And the basal is twice a day.
Most of the time it's going to be once a day. Yeah. So like I said, like 4 injections is a fairly common approach where you do the basal in the morning along with your mealtime short-acting insulin, and then you'd have your lunchtime and dinner time. Some people will have a correction at bedtime where they will, depending on, you know, if it's more of an as-needed kind of thing, where if they are hyperglycemic, they'll get a dose at, you know, around bedtime. There's all kinds of stuff where if like they wake up hypoglycemic, you get to figure out if like the dose of insulin at night was too big or too small, and there's kind of other stuff, but it's kind of beyond our discussion here.
For the thyroid section, for someone who has hypothyroidism, you would go with the Synthroid, but when would you use the Liatrix?
I don't see it used very frequently. For the most part, I'm trying to think of any time I've actually ever seen a patient use it. I've seen it on the shelf in a pharmacy before, but honestly, Synthroid is like just far and away the one that gets used most commonly. It's not OTC, no. No, all your thyroid medications would be prescription only, because again, you want people monkeying around with their own thyroid hormone supply.
What does it mean by more natural?
So if you look at it, you mentioned like there's the 2 major forms of thyroid hormone circulating in the bloodstream is T4 and T3, right? Usually you have a bigger supply of T4 circulating around than T3. Which one's the active form? T3 is the more active form, right? So the Synthroid, which is only T4, gets converted over into T3. So that's one of those things where it's like, say you had a patient who overdosed on Synthroid. It's one of those things where they call up and they're like, oh no, what do I need to do? It's like, well, let's see how they are in a week, right? Because it takes time for that to get converted over to T3. You wouldn't actually see symptoms of that develop until farther down the road, which is kind of interesting because when we have like organ donation patients, oftentimes their brainstem just totally kind of goes out the window, and so we end up having to regulate a lot of their normal functions. So things like vasopressin, we're having to give them drips of, we're having to give them Synthroid drips in order to help maintain their endocrine function until they can harvest the organs. But it's kind of interesting because when you think about giving T4 IV, like it takes so long for it to work anyway. I don't really know how effective it's being, but that's what their regimens are. Yeah, that's also another thing on rotations. If you get to see a patient who is declared brain dead and they're going to go for organ transplant, check out the TransLife people that come in, because they're usually they're nurses working off of protocols, and they have all their own drugs they come in with, and they have a very specific regimen these patients get put on. They're usually on insulin drips, vasopressin drips, usually vasopressors, because again, you can't really regulate your blood pressure very well when you're brain dead. But it's very, very interesting if you ever get a chance to interact with some of those patients. Even like the tests they do to test for brain death is interesting, with like ice water in one ear, and you have to look to see how the eyes react and all kinds of interesting stuff. They go for brain scans as well. Yeah, so you have to have a couple different confirmatory tests by different physicians who are, credentialed to do that sort of thing because they want to make sure like you're really dead
Yeah.
when But they've had cases where they've actually had like overdoses of I think it was baclofen. Is it baclofen or like cyclobenzaprine or something? And this one lady was completely comatose. They were just like, well, she's brain dead, like no. So they went to go send her for organ procurement, and right as they were about to cut into her, she woke up. Yeah, so imagine that, like you're about to get, yeah. Yeah, like, wait, 1 second, please. So, just lots of interesting stuff out there.
I have one more question.
Yes.
With the iodine.
Yes, iodine.
How does that work? 'Cause I know my grandmother's she gets IV.
She got IV infusions of iron or iodine?
I asked her, she doesn't really speak English. She says that she keeps getting these IVs, and I keep asking her, are you sure it's iodine? She says, yes, iodine. But, I don't know, she has a thyroid problem, she is diabetic, she's anemic,
Yeah, it's probably iron injections if I had to guess. That's probably the more common thing. I would say I don't really see IV iodine being given. You do for certain, there's certain iodated contrast media, right? So that's one of those ones I mentioned, the ipodate one that you can use sometimes for thyroid storm because it helps to actually limit further production. So iodine's kind of interesting because if you give it in kind of normal amounts, and if you actually go outside of the U.S. into more like developing countries, like having hypothyroidism, having these goiters is like it's a much more prominent problem because a lot of their foods aren't fortified with any iodine, right? So salt and things like that. So as long as you have a normal amount of iodine, it helps to stimulate thyroid function. If you have too much iodine, that actually inhibits thyroid function. Okay, so that's where they could have issues, especially where like really young patients, like neonates. Like if you were to use the povidone iodine, like the antiseptic rinse, they use like for to clean surgical sites and things like that. They can actually have absorption because their skin is thinner and doesn't have a really good developed stratum corneum, and they can end up having hypothyroidism because they're getting too much iodine absorption. Sometimes they will. Trying to think. You don't want to use like isopropyl alcohol because they can absorb that too and have issues. Probably chlorhexidine is probably the more common one I see being used.
So how would this iodine be?
So it depends. Like, are you trying to stimulate thyroid function, or are you trying to inhibit it, right? So especially if you had like if you were to have say like a cancer that you were trying to kind of shrink the thyroid gland down in order to resect it. Sometimes you use concentrated iodine solutions in order to help inhibit the function there, and so it actually can shrink the tissue, make it a little bit easier to excise. Sometimes you're just using it as trying to get a normal amount of iodine in the diet, so that way they can have good normal function. But basically, just by having too much iodine around, it just inhibits that whole process because the thyroid's kind of thinking, hey, I've got enough iodine around, I must not need to make any thyroid hormone. It's not as clear cut as you see with like how the T4 and T3 kind of have that negative feedback loop, like on the pituitary and the thalamus, or the hypothalamus. But it's kind of a similar process. Any other question? Okay, so I have a couple slides we'll go through. Generate some talking points. So we talked about Parkinson's. You guys already took a quiz on that, so you guys should be well versed in all matters Parkinson's, right? Fantastic. Remember which ones are neuroprotective? Do you guys remember which ones are? Dopamine agonists, MAOB inhibitors, perfect. Which ones are going to work for specific symptoms, right? We kind of already covered questions like that, where anticholinergics are better for tremors. If they're having more kind of hypokinesia, more dopamine-based products are going to be better for that sort of thing. Remember the dietary interactions? You guys remember what interacts with like selegiline? The good stuff. What kind of good stuff? Aged cheeses, red wine. There's red wine specifically, not just like any wine. Fava beans, yep. So like if you're Hannibal Lecter, you have a nice fava bean, a nice Chianti, you don't want to do that, right? Okay. And then remember how to we manage like the later stage complications. We mentioned, remember that one quiz question where it was like, patients having early off symptoms. What can we do for that? And it was, use a controlled release. Well, no, remember that was the one where we use a controlled release formulation. Some people got that one wrong. That's okay. But you know, say for instance, like, you know, with their doses of Cinemat, they were having you know, dystonias, right? Because remember, as they get more progressive, that kind of window where they have relief of their symptoms without the dystonias gets narrower and narrower. You know, what would you do if your peaks were too high and you're having dystonic effects? How would you do that?
Lesser dose.
Yeah, so you could try lowering your dose, but now you say you have more hypokinesia. So controlled release format may be useful for that as well, because again, remember, you don't get high peaks, but you get nice kind of a plateau type of effect. So that could be one thing you could do. You could maybe use a lower dose plus like an MAOB or like an entacapone on board, a COMT inhibitor. So lots of different options you have for that kind of stuff. Say for instance, you had a patient who you tried to maximize their levodopa dose, but it's still not really working. What's a dietary modification you can make to help make the levodopa work better?
Separate it from meat.
Yeah, separate it from protein, right? Because it's all going through the same amino acid transporter. So remember kind of tricks like that in order to help overcome those kind of complications. Okay. Any questions on Parkinson's? All right, you guys reviewed that pretty well. MS, remember the couple different phases of therapy we have for that. So we have management of acute exacerbations. What's the main drug we use for that, or type of drug? For management of acute exacerbations. Yeah, methylprednisolone, corticosteroids are really the big thing for that one, right? Those are good for acute exacerbations, and then we use the disease-modifying therapy for more, I don't know why I put DMT therapy, because it's like DM therapy, but anyway. But remember, you know, the adverse effects you can run into, like risk for infections. Remember, like interferon, what kind of interactions? Yeah, lots of, yep.
Don't forget that.
You'll never forget that one. See, oftentimes the questions you miss are the things that stick with you the longest. I'm sure I still have a few from pharmacy school that are still like, I can't believe I got that wrong, but I'll never forget it. Ever. Right, but you know, other problems you can have with that, there's like myeloproliferative complications, potentially lots of black box warnings for interferon. That's why we don't like to use it. That's why we like our oral agents for that. And then like other symptom management. So we talked about like the anticholinergics for, you know, like the incontinence. You know, if you're having spastic issues, what are some drugs you can use for muscle spasms? Not the bladder, but for just like muscle spasticity. Baclofen's a good one. Flexeril, what is generic for Flexeril? Cyclobenzaprine. What if none of those are working? What could I try? Gabapentin, that's kind of wimpy, but yeah, it could work potentially. But that's not working. TCAs maybe. BPRs. Valproic acid? Yeah. They may have some help, more like neuropathies and things like that. But think about like Botox, right? So think about like, you know, using the world's most deadliest toxin in order to paralyze some of those muscles, right? So that's a possibility too if they had really bad muscle spasticity. So keep all those different types of drugs in mind. Okay. Okay. Headache disorders. What are some drug causes of headaches?
Well, one treats it that could cause it. Is that really? Like propranolol.
Propranolol could cause it. Yeah, that's true, because it's causing what? Vasodilation. Absolutely. What else could do it? Yeah, so taking too many pain medications, right? Often the NSAIDs mixed with other things, you know, can lead to medication overuse headaches. Absolutely. How about withdrawal from certain medications? Like what? Caffeine's a big one. Yeah, remember caffeine. Sometimes alcohol withdrawal can exacerbate that as well. So there are lots of different causes for that. Remember the mechanisms of our drugs? What's the main one that works for treating migraines? By?
It keeps like a baseline.
What receptor?
1D.
5-HT1B and 1D, right? So those are the main ones you see there. Let's see what else. Remember who's contraindicated, so you may get like, okay, patient comes into your urgent care, they need therapy for their migraine and they're pregnant. What do you want to use? Nope, said no drugs for you. Sorry, lady. You and your baby, get out of here. You give them more opioids? I don't know if I want to give them opioids. You're a nice provider, jeez. I'm coming to you. I'll stub my toe. Can I get some Dilaudid? Yes.
Drug trafficking.
Press Ganey scores are going to be off the chain. So think about, so obviously, like, what's the big contraindication for pregnant women in migraines? Ergots, right? So certainly you could try using, you know, things like NSAIDs if it's not the third trimester. You could try things like Tylenol if those are not working. You know, certain opioids possibly, but not usually for migraines. But like your triptans are, you know, category C, no real evidence for harm. It's probably okay to use if they've exhausted other therapies, right? So keep those kind of things in mind. Yeah, NSAIDs you don't want to use in the third trimester. Yeah, first two is probably okay. Yeah. Okay. Any other questions on headaches? Besides about how to treat the one you get every time you come in here on Wednesday night, 5 o'clock. Magically disappears at 7. I don't know about that. You guys can't butter me up. Can't butter me up. Okay. Okay, do you guys want a free answer on the test?
Yes.
C, it's C, yeah. There's at least one C on the test. Okay. Okay, going to HIV, remember, be able to identify drugs as they fall into their mechanisms of action, right? So be able to identify, okay, is this an NRTI versus an NRTI versus a PI versus integrase inhibitor, all the different classes, right? Because you should be able to kind of recognize what kind of regimen makes sense, which one doesn't, right? So how would you design an HIV regimen? 2 NRTIs, 1 PI could do it, right? What are PIs normally put with? What do you normally put a PI? Yep. So which the R1? Yep. Ritonavir, right? Ritonavir is the booster. So usually that would be like a 4-drug regimen. We have ritonavir booster. Remember that Cobicostat can do the same thing potentially. What could be another good regimen? Yep, you can use an integrase inhibitor instead of a PI, right? So that could be one, right? Those are probably the most common ones you're going to see being used out there. But you could also use like an NNRTI plus 2 NRTIs, right? So that could be an okay regimen as well. So like using like something like itrovirine could be used in that combination. We actually, and if you guys would go back to your post-exposure prophylaxis, I actually had one of my wife's friends had they have twins. They are probably 1.5. And their mom is not so hot on vaccines for her own personal reasons. That's okay. But anyway, so her kids were out playing in the park, and one of them came up and said, "Owie." So out in the random park, there was an insulin pen needle the kid had managed to stick himself with. Like, is that not your worst nightmare? Like, if my child got stabbed by something like that, I would want to kill whoever left that needle out in the wild. But anywho, so they have to now consider post-exposure prophylaxis. So what kind of things do you have to consider? What kind of bloodborne transmission diseases? HIV you have to worry about. What else? Hep C, Hep B, worry about tetanus. Yeah, so you got to worry about all the different things, right? And so obviously their vaccination records were not up to date, so they ended up having, so they actually got referred over to they went to the ER that one night. They referred them over to infectious disease, and so they were going to go ahead and they started them up on the Hep B series of vaccinations, and they did the Hep B immune globulin as well, because again, they're like 1.5. Yeah, so they're already late on the Hep B stuff. Could normally wait till Hep B you normally get around birth. Yeah, so he should have already been finished with his series. He didn't get any at the time, but I think he'd gotten some. Like she was wanting to do like 1 vaccine at a time, so he was really kind of behind on a lot of that stuff. But anyway, so he ended up getting the immune globulin plus the starting his Hep B series, and I think they were just going to do HIV titers and now I think like a 3 months or something. And if they did find anything, I was like, so my kid, I probably want to put him on Truvada like immediately and just, yeah. But anywho, so that was interesting, at least in your real world case. Let me get Louis first and then you.
So, from my understanding, like once you're on a certain regimen and you mess it up or whatever, you stop taking it, you can never go back to that same one. Correct?
Depends on the resistance patterns. You're less likely to be able to use that regimen again because you're probably selecting out for resistant HIV. But there's a possibility you could use it again. It's like a lot of like the PIs, they're really tough to get resistance towards. Some of the like NNRTIs are pretty easy to get resistant towards. Like there's one of the ones that have like a single mutation resistance. But it just depends on the virus.
The reason why I ask is like for like some of the post-exposure, they were very similar to some of like the mainstays. So
Mhm.
you know, if you were to use the post-exposure, and then like later down the road, 10 years ago, 10 years after you get actual HIV,
Mhm.
you can't use it again.
I probably not, because ideally, if you had post-exposure prophylaxis and you eradicated the virus, then you wouldn't have any virus. You'd be starting off fresh again, right? But yeah, who knows? Because whatever you were picking up could be already resistant, depending on who you got it from and all that. Yep. Yes, ma'am. That was it. Okay, so these things do come up in real life every once in a while, so keep that in mind. Okay, guys remember opportunistic infections? What are some good examples of those? PJP or PCP pneumonia. What do we treat PCP with? Yep, Bactrim's a go-to drug for that, right? So again, if you ever see a patient who's like on Bactrim Monday, Wednesday, Friday, or if they're on it for like 2 days out of the week or something, that's usually what it's on board for. How about for thrush? How do we treat that? So you can do switch and spit nystatin. What if it's more kind of esophageal? Right, because you guys understand why that is? Like nystatin doesn't get absorbed, right? So it's only going to be good for like kind of topical treatment for things. So it's more for mild disease. Usually for those type of patients, I say just switch and swallow, right? That way you can kind of coat whatever else kind of down the esophagus. But yeah, if it's starting to get more esophageal, if it gets more disseminated, that's when you need something like fluconazole, right? Sometimes these patients we have to put them on even like stronger antifungals. There's lots of other IV agents we use sometimes. I see this more in the case of chemotherapy kids who end up getting secondary fungal infections, but the immunocompromisation is almost identical to something like HIV.
So if it is esophageal, you would use eclocan versus nystatin?
Mm-hmm.
So why do you swallow
You
it?
can't just swallow.
Huh? You could swallow, but as it gets more progressive, you're more likely to see kind of translocation of the fungus, and you're more likely to get systemic disease, right? And that's really the biggest thing we want to do is prevention for these guys, and not trying to treat, because fungal infections are always going to be more difficult to treat than the bacterial one, because they're slower growing. It's hard to hit the fungal cells in the kind of active reproduction cycle to really arrest growth. So you always want to be careful with fungal infections for these at-risk patients. Especially if you ever get like you ever see like a really bad ICU patient got like a nasty fungal ball in the lung, like that can be really, really hard to treat. Sometimes they actually have to go in and with a scope and actually like try to remove the actual fungal ball, because otherwise you can't ever penetrate it enough to eradicate it. So this can be really tough to treat.
So if it was an esophagus, you'd rather than switch and swallow nystatin and putting them on like fluconazole?
If it's starting to get esophageal, that's where your risk for it going systemic is greater. That's when I would consider using fluconazole, right? If it's just in the back of the throat, then you're probably okay just using the oral. I tell them just switch and swallow anyway, just so that way you can kind of just go ahead and coat down the esophagus and get anything else that might be growing in there. Okay, just in the interest of time, we'll just keep going. Remember our common treatments and common diagnoses for STDs? Remember, if you're treating someone for gonorrhea, what else are you treating them for? Chlamydia, right? So what's the treatment for chlamydia? Azithromycin is usually the common one to go to, right? Why do we do something like azithromycin? It's one dose, right? Because remember, a lot of these patients you want to do as easy a therapy as possible. So if you can do a single dose in the ED or in the urgent care center, like whatever you can do, that's all going to be a lot easier, right? One dose eradication. And then the gonorrhea, what do we treat that with? Yeah, using an IM dose of Rocephin. How about syphilis? Yeah, so that's not, so usually Pen-G is the most common one there. Again, remember that's a much slower growing kind of bug, so you need to treat that for longer. Usually kind of continuous treatments, that can be really tough. Let's see what else. What kind of, so if I was treating a more mild case of syphilis with penicillin, what would be the go-to drug form for that? The IM benzathine penicillin G, right? That's that bicillin. That one has a really long duration of action, so that way you can get away with the one dose kind of treatment. Okay.
So, sorry, back to the gonorrhea.
Yes.
Does Rocephin treat both? Or is that solely for gonorrhea?
That's solely for the gonorrhea. That's why you give a dose of azithromycin plus the IM shot of ceftriaxone.
Okay.
Right, yeah, you do both of them, because that way you're treating both at the same time, just because co-infection is so likely. Yes, sir.
You said bicillin for a mild form. What about for a more serious form?
If it's more serious, usually they have to come in and they have to get IV treatment with penicillin G. So they might either be like on a continuous infusion of it, or like every 4 hours or so they'll end up getting IV doses of penicillin G.
Okay.
Yep. Okay, and then hepatitis. Remember kind of the newer forms of treatment, because before, what type of drugs did we use for hepatitis, like C? interferon, like ribavirin. Like remember, ribavirin has a kind of similar toxicity profile to interferon. So like lots of neuropsychiatric issues that we're developing there. You have depression really bad. So again, you're already depressed. You have Hep C. So now it's going to make that even worse, right? It's no good. So now we have those direct acting agents, right? You guys remember how any of those work? The direct acting agents. You guys remember how those work? Yeah, so there's a couple of those different proteins that are inhibiting, whereas it'd be like the N5SA or whatever happens to be, whether it prevents like cleavage, right? If it acts like kind of like a protease inhibitor, or if it acts as a chain terminator for the RNA proliferation, whatever happens to be. Remember the different mechanisms there. You have to kind of identify those, right? Okay. Any questions on that section? And then we talked a whole lot about diabetes. I think you guys are pretty good on that. If I had to treat someone who's hypoglycemic, so say like they're just like, oh, I'm just feeling really crappy, I'm sweaty, and I'm shaking, and I'm really hangry right now, how would you treat their diabetes or their hypoglycemia?
Juice. Give them juice.
You want juice? Okay, so yeah, so what was that rule of 15 we used?
15 grams.
15, which is how many grams of carbs?
15.
Roughly 15, yeah. So again, 8 ounces of OJ, 8 ounces of orange juice, whatever happens to be. At Nemours, we actually have slushy machines in the ED that are really good for like PO challenges, so we can give them a little bit of slushy. Like it's probably the fastest acting sugars you can get in your system. You got to be careful with the employees wheezing the juice as it was. Stay away from the blue raspberry. It shows in your mouth for hours. You don't want to do that. The lemonade one, though, you're in the clear. It doesn't show up too good. Anywho. Yeah, so again, wait 15 minutes because again, normally what will happen is they'll kind of overreact and they'll end up eating too many carbohydrates and they get hyperglycemic. So that's just a natural reaction. I know I've probably done that several times. Where I'm just like, I must eat everything in sight, and then I'm sure my blood sugar's like 500 after that. But so that's normally the way you do that. Now, if your patient cannot tolerate oral, what would you do?
Sublingual.
No.
Mucosal.
I hadn't thought about that. So that's probably a good one. Yeah, interesting. So remember, what drug do you use? Glucagon, right? So you can use glucagon. That's IM. That's pretty smart, though. I hadn't thought about it. Just applying, slathering some icing on their gums and.
The icing that you used to like write on birthday cake or whatever is really good because you just get it right into the gum.
Yeah.
And it'll go right to the brain.
It's pretty smart. Bypass the first pass effect and everything. I like that. It's good. Yep, so we will sometimes use glucagon, right? Again, you need to have glycogen stores in order to actually have any kind of response, right? Because if you don't have glycogen, it's not going to do anything, okay? And then what else could you use? Dextrose, right? So you use IV dextrose. So again, keep in mind the type of patient you're doing. So if a question came up and it was like, okay, the patient's awake and alert, but they're feeling really crummy, like what's going to be your best option to treat their hypoglycemia? And you're like, their blood sugar is 65 and they're feeling really crappy. You're not going to say, okay, let's give them a AMPA D50 and then glucagon. Like it's a little overboard, right? So keep that in mind. But if your patient's like comatose and they just had a hypoglycemic seizure, okay, that's a whole nother story, right? So need to use IV therapy.
Does that have to do with weight?
A lot of it has to do with the size of the patient, right? So for older, like adult patients, especially if they're comatose, like if you open up your crash cart, like you have D50 available too, you can give that in the veins. Because what's the problem with using concentrated dextrose in the veins? Extravasation, you can have thrombophlebitis, you can collapse the vein pretty easily that way because it gets so irritated. So usually for smaller patients, usually like peds patients, like D25 is going to be preferred. D10 is best because it is more dilute. You obviously have to consider, what kind of volume status can your patient tolerate. If they are already have way too much fluid volume on board, maybe D10 is inappropriate for them. Maybe D25 is better. Obviously, if you're getting higher concentrations, central line is always going to be best for things like that, but in a lot of cases, you may not have that available to you. So just keep that in mind. So think about the state that your patient is in. Obviously, oral things are not going to work for people who are comatose unless you have cake writing icing in the ED ready to go in your crash cart. That'd be a good thing to consider keeping in there. Or do like some peanut butter or something like that too. Probably stick around for a little bit. It's fast acting. Yeah, that probably won't wake them up. We usually give them like peanut butter too, because this is kind of a nice little bit slower digesting carbohydrates. So kind of when you give them like some fast acting stuff, and then like graham crackers and peanut butter, and it usually kind of keeps them up. But anyway, trying to think of the last like really good hypoglycemic kid we have. Had a few seizures from hypoglycemia. That was going to be a little scary because again, your initial treatment choice for seizures is what? Benzodiazepines, but that's not going to really work for that, right? Like you need to replace the sugar, right? So then you have like someone who's really snowed from all the benzos, and then also the hypoglycemics. That's why you always check an IQ check anytime you have a patient with altered mental status, right? Anytime they're altered, check an IQ check because that's an easy thing to rule out and treat. Okay, always think about that. Mentioned the androgens. We'll talk a lot more about, when we get to the OB-GYN section, we'll talk a lot about the estrogens, so ladies, don't worry, we'll get there. I had to explain the menstrual cycle and polycystic ovarian syndrome to a female colleague of mine one time, and she said, you know a lot about the period, and I thought that was one of the highest compliments I'd ever been paid, so I was like, if only my wife could hear this. I do understand a little bit about women, just not their emotions. But anyways, we talked about androgens. Again, why don't we like to use oral androgens? Not stomach acid. They get absorbed okay. They're tough on the liver, right? So you can cause cholecystitis. You can have hepatitis from it. Like this is why when bodybuilders are using androgens, they're always injecting it, right? They're using IM injections, not oral, because that really puts you at risk for hepatotoxicity. So that's why you see a lot of gels, you see a lot of creams, you will see patches, IM injections. Those are usually the most common dosage forms for androgens. Keep in mind that also, especially when we get to the OB-GYN section, we're talking about estrogens, the same thing applies there. Like, you're more likely to see hepatic effects from orally administered estrogens than you would from something like vaginally applied or transdermal. So that concept will come up again in the last section of the class. And then let's say we had a patient who came in and they were in adrenal crisis, adrenal insufficiency, they're hypotensive. How would you treat that? What would you give? You said cortisol. What's another name for it? You could. Prednisone might take a little long. Hydrocortisone is the big one, right? Because remember, your steroids can either have glucocorticoid effects or mineralocorticoid effects, or some mixture of the two, right? So for those type of patients, if they're hypotensive and they're not really able to regulate their volume stats very well, you need something with more mineralocorticoid effects, right? So those are things that are going to help to retain salt and water and keep the intravascular space filled up. So things like fludrocortisone or hydrocortisone are your go-to agents. So for instance, we had one patient who had she had a pituitary adenoma that had been removed, and so she was being maintained on oral fludrocortisone at home to help maintain her blood pressure, right? Because her pituitary was gone, so she couldn't really regulate all that stuff on her own. So she was on Synthroid, she was on vasopressin, which is antidiuretic hormone, to help kind of regulate her normal endocrine function, right? So she would oftentimes, if she got like a virus or if she got stressed out, she would very frequently come in very hypotensive, tachycardic into the ED from adrenal insufficiency, right? So we ended up having to give her big bolus doses of hydrocortisone to pick her back up, and then kind of do a taper from that back to her oral meds after a while. So she would come in, she'd probably be in the ED at least once or twice a month for that same thing. So keep in mind how you would end up treating that based on the pathophysiology of the patient, right? Okay, we mentioned thyroid hormone. We kind of talked about that a little bit. Synthroid is the go-to drug for thyroid replacement. What are some ways that we can inhibit the activity of thyroid hormone? Okay, how do we do that? What drugs can we use for hyperthyroidism? Talked about two of them. Well, no, that's for replacing if we want to inhibit production of new thyroid hormone. PTU, which is propylthiouracil, right? And then there's one more, methimazole, right? So those are preventing the actual formation of thyroid hormone. So keep in mind, all those thyroid drugs, they take a long time to work. That's why when you're if you're treating a patient for hypothyroidism and you start them on Synthroid, do you guys know when you check the TSH next? No, like 6 weeks, 6 to 8 weeks or something, right? Because you have to give it time for it to really kind of get back to their new set point for them. Because again, the Synthroid takes a while to get converted to T3. It takes a while for that feedback loop to start to get affected, right? Because normally patients who are hypothyroid, what are their TSH levels? They're high or low? should be high, right? Because again, that's your TSH, that's your thyroid stimulating hormone. So if you're not making enough thyroid hormone, then you need something to stimulate it, right? So that's why you try to see, you'll see that high initially, and then as you get their T4 and T3 levels back in check, then you'll see the TSH come down, right? So think about the kind of feedback loops that are happening there, where the actual product you're trying to make will feed back and inhibit those kind of trophic hormones from being released, okay? So again, if you have hyperthyroidism, the same thing is happening there, where basically it takes time for those drugs to work, because you still have the circulating thyroid hormone that's working, but if you give PTU or methimazole, it'll take time in order to help decrease the amount of thyroid hormone actually being made, right? So all this stuff takes time. That's why if you have a patient who has like thyroid toxicosis, oftentimes things like PTU and methimazole are not used for that acute time frame. Usually you're using things that are kind of dealing with the side effects of that. So usually things like propranolol to do with like hypertension, tachycardia, things like that. I didn't really talk too much about thyroid storm, but you'll see that you use certain drugs for that. But mostly you can't do anything with the already circulating thyroid hormone. Okay. So any other questions I can answer for you guys? Don't be scared. You'll be fine. Yep, so email me if you have any questions. I'll be happy to answer up as long as I can, and otherwise I'll see you guys on Wednesday. Thank you.